Good evening and welcome to the Henry Schein Dental Academy webinar series. My name is Corinne and I will be your moderator. We are excited to welcome Dr. Marc Geissberger as our speaker today. He will walk us through best practices and leading solutions available from 3M to ensure that restorations maintain their longevity and strength over time. Before we get started, we do have a few reminders for you. At any point during the webinar, if you have questions, please type them into the Q&A section of your control panel, and we will answer them live at the end. Henry Schein is not offering CE credit for viewing or attending this presentation live or on demand. And this webinar is sponsored by 3M. Dr. Geissberger, welcome, and thank you for being with us.
Karina, thank you so much for having me, and welcome everybody to my webinar this evening. I want to thank you all for being here. I know some of you probably just finished a long day in practice, as have I. I've been here since 7 in the morning, so all is good. And I'd like to welcome you to this program. Now, 3M asked me to speak on prevention from a dentist standpoint of view and really go over a few things that I think can really help your restorations not fail prematurely. So with that said, I want to give you a little brief background about myself and just fill you in just a bit. I am by nature a teacher. I've been teaching at University Pacific School of Dentistry since my graduation in 1999. And I've been an adjunct professor on the school since 2018. In addition to that, I have a private practice here in Marin County, where I practice with my brother and my father. My father was my inspiration as a dentist, and it's great to have a family practice and practice with my brother. In addition, I do a lot of product evaluation and work with industries for new products or materials, maybe technologies or delivery devices, and give them feedback on how to position things. In addition to that, I'm with a group called Catapult Education, founded by Lou Graham out of Chicago, Illinois. We're a group of 25 like-minded speakers who speak nationally and internationally on various dental topics. In addition to that, I have a family, 3 kids and a wife. And my hobbies include car restoration, woodworking, organic gardening, and painting. So that's how I spend my spare time. Well, with that said, I want to give you my Instagram. I'm Marin Dentist, or on Facebook, I'm Marc Geissberger DDS, and encourage you to follow me on either. If you don't get your question answered in the Q&A tonight, I encourage you to email me at mgeissbergerdds@gmail. That's my Gmail. And I'll get back to you with answers to your questions. Now, as Karina had mentioned, tonight's program is sponsored by 3M and Henry Schein. You need to know I'm not a hired thug of any company. I work at a lot of companies in industry, and I really talk about products I use and recommend in my practice to patients. So that's really important that you recognize. And I want to thank both 3M and Henry Schein for having me give you this webinar and present to you. So let's get started. Now, I want to talk a little bit about dental caries. Now, I know we've got a lot on dental caries, but here's the deal. I've watched my own restorations crumble in the presence of caries after I spent an inordinate amount of time, my time, the patient's time, expenses, to restore a patient, only to watch it crumble. So we need to recognize that caries is still the most prevalent disease to humankind. So there's really 3 things we need to look at when we talk about managing dental caries. The first and foremost is preventing the disease from ever beginning, meaning don't allow a single tooth to get caries. And then we always have the restorative management of caries. That was what I was trained to do. We watched a lesion until it got big enough, and then we restored it with some composite or a crown or whatever. But more importantly is that third strategy, which is the non-restorative management of caries diseases and diseases of acid, really. So that's important to recognize. Now, recognize that caries is a disease of acid. The acids plague tooth structure. Not only that, the bacteria that cause the caries release those acids that break down tooth structure and allow the disease to progress. Now, there are other diseases of acid I'm going to talk about a bit, and some of the management styles. But I want you to keep in mind that whether you have caries or, say, erosion, abfraction, those type of things, erosive disease and caries are very similar, that they're both driven by acids. And there's strategies we need to control those acids to make sure that we don't have our patients succumb to the disease. Now, this is really interesting. This is a patient I tracked for many years. They came to me as a new patient, and I thought I was doing a good job. They had a lot to do. And I had a treatment plan. I said, look at this radiograph. We've got decay on 31. We've got decay on 29, both mesial and distal, very large on 29. We've got decay on 28. And I look at these old, larger amalgams, and I come up with a plan. Now, whatever the plan is, I didn't interrupt the disease, meaning I just filled the cavities. So upper arch, look at tooth number 2. Look at number 3, mesial. Look at 4, distal. Look at 4, mesial. Look at 5, distal. The list goes on. And some of these we choose to what? Restore, and others we choose to monitor. And that's really been the two strategies we use to deal with dental caries or diseases of acid. So here's the bite wing, and then we go ahead and restore those. But here's the interesting thing. Look at this bite wing a year later. Now, if you go back and look at 3, right here, if you look at 3, it was not through the enamel. But look at it now. The disease in 1 year's time has progressed. Look at number 2. It's now got a lesion. Now, these were all well-placed composites, but the problem is now I've got to come into 4 and treat that because I never interrupted the disease. Unless we interrupt the disease, the problem is this patient is going to suffer. Now, take a look at the patient's left side. And I ask you, how did they lose number 20? Well, the most common causes of tooth loss are periodontal disease and caries, followed by occlusion. But when you look at this patient, you can see they're really free of periodontal disease. So even though they're a new patient to me, I would surmise that they lost that tooth to caries. Maybe they had a root canal. Maybe that root canal and crown led to a vertical fracture. But ultimately, caries led the way. Now it's neat because what do I get to do? A fancy implant. But take a look at number 12, mesial, which we put a watch on. We're going to watch that for a while we treat the disease. The problem here is that we decide to treat that disease and the disease of lost tooth, but we really never interrupt number 12. So a year goes by, we get the implant done, we get a new crown on number 19, and look at now the mesial of that tooth. It is plagued with the disease. And the problem is this will not stop for this patient unless we change our strategies. You take a look a year later. Now what you saw in the mesial of 15 is progressed from nothing here, 1 year. 1 year later, yeah, I can see a lesion, and that gets restored. Number 19 gets a crown, number 18 gets a crown, and we'll chase this around the mouth. But here's what happens ultimately. We will see our own restorations fail, and that is problematic. So what I want you to recognize with tonight's program is we're going to discuss how to really protect those things that you do and really protect the patient. We've got a lot of science behind this, and this is evidence-based. What should we do? What shouldn't we do? What should we use for these strategies? So we'll go over that just a bit. I'm going to do it in 3 segments. Keeping the patient free of disease, doing the disease surgically like this. This is the surgical approach, and then the non-surgical approach to this disease. Now, let's talk about preventing the disease from ever beginning. I think one of the greatest introductions in dentistry has been caries risk assessment. Now, in dentistry, we were great at periodontal assessment. We'd take readings, we'd take pocket readings and recession, we'd come up with a diagnosis, and we'd develop a treatment plan from there. Caries was different. Caries, we looked at a radiograph and said, I can't tell, and we'd stick something in it and say, okay, that needs a filling or not. But here's the problem. We had no really good way of quantifying the disease like we did with perio until the Camber Coalition looked at becoming better at diagnosing caries and assigning it probabilities, similar to that of staging a disease and assessing its veracity. So what we look at when we do a caries risk assessment, and if you're not doing this currently, I really have to say you got to get on with this. Move into this century and get on with caries risk assessment. The first thing you look at is evaluating what we call the disease factors. Those are like visible cavitations, cavity in the last few years, radiographic evidence of that, and white spot lesions. Then you look at risk factors. Do they have adequate salivary flow? Do they have appliances present? Do they have deep pit and fissures? The exposed roots? Do they suffer from GERD or Sjogren's syndrome? Are they on hyposalivation medications? Those type of things. Have they had radiation therapy? And here's a biggie. Do they snack a lot between meals? Do they drink regular sodas? I'm going to talk a little bit about regular sodas. Do they use recreational drugs? And then finally, protective factors. And here's what we're going to talk about tonight. So they have some disease factors, they have some risk factors, and those increase the probability of getting the disease. To level this scale, what we need to do is tip things so that we add protective factors. And it's not only fluoride. Fluoride's a big component, but phosphate, calcium are huge in preventing the disease of caries. Not only that, where are we at with bacterial management, therapeutically, chemotherapeutically? So do they use xylitol? Do they have a form of fluoride and calcium and phosphate? And how are they getting that to the tooth structure? And once you assess all this, you put them at high, moderate, or low risk. Now, believe it or not, even if you're at low risk, you can still get the disease. The probability is greatly reduced. But if you want my caries risk assessment form, great. If you don't want mine, go to the ADA and download this form. It's a brilliant form, easy to use, and I think it's paramount that we all start doing this, because once we assign a patient to moderate or high risk, our recommendations have to change. We need to get the patient to own their disease, to take control of their disease. So get involved with caries risk assessment and then have a strategy. Now, this all came out of very progressive thinking from a few individuals in dental schools who said, hey, we do terrible with caries. It's still the most prevalent disease in the world. And in fact, decay rates have gone up, not down. Yet we know what causes it. We haven't been really good at curbing the disease. So I give a lot of kudos to Doug Young and Buchanan and Lubman and Broadway and Novi and all these individuals who really looked at this. Now, I want to talk a little bit about restorative management of caries. You need to first of all think about focusing on preventing the disease from spreading. So how do we do that? Well, keep in mind that any pit or fissure that has bacteria present can be the site of inoculation to other areas in the mouth. In fact, even though we brush, we do certain things, we can move bacteria around. So one of the things I really want to talk about is the underuse of glass ionomers as a triage material in dentistry. 3M makes a brilliant product called Ketac Universal Applicap, which is a great GI, but it's grossly underused in the dental world for managing caries and ensuring that our restorations last. So think about when you patch a crown. What would we use to patch a crown with? Amalgam? Well, that was a terrible patch, but we did it. Composite? Not great on roots, especially in a high caries rate. Look at glass ionomers. They'll prolong your restorations. The evidence is there, and I'm going to share that with you. Now, there's lots of GIs in the market. Ketac is a brilliant one from 3M. Fuji from GC is a good glass ionomer, and so is Ionostar Plus. But I really encourage you to look at these products and begin to use them in these high caries risk patients. Even in the acidic patient, and we'll get into that just a bit. Now, I'm going to show you a couple of things. First of all, glass ionomers' effectiveness in curbing the disease of caries is well established. Now, there's several studies that looked at these, but this happens to be a meta-analysis of controlled, randomized controlled trials that looked at certain things. And this looked at the use of glass ionomers, and SDF, sodium diamide fluoride. And the glass ionomers are used in conjunction. This is really important that you recognize this with fluoride varnishes. Now, what they showed with SDF and with glass ionomer and fluoride varnishes is a huge, huge decrease in the disease rate. 94%, 94.5 for SDF, and 90%. They were able to curb the disease by 90% in this patient population. And this was an underserved population or a struggling population, and it really did lower the caries rate. Unfortunately, glass ionomers are a great restorative material. I use them daily, but there's no evidence they actually lower the caries rate in individuals. Now, take a look at this, and I want to give you some food for thought with caries. This patient comes in who really needs a full mouth reconstruction, but the decay rate is out of control. If I start popping restorations on teeth here, whether it be glass ionomers, composites, or crowns, and I don't address the disease, the crowns and the glass ionomers and composites will fail. Which one fails at a slower rate? Honestly, when an out of control disease, it'll be the glass ionomer. But in this patient, we want to look at glass ionomers as an ability to transition the patient towards a full mouth reconstruction. Now, what do I mean by that? This patient's got such rampant caries that if we intend to save any teeth, we've got to get the disease under control. So the first thing we'll do is eradicate as much caries as we can and place glass ionomers. Then get them on a system that allows them to get the disease under control. So what I encourage you to look at is ways to improve oral hygiene, of course, strengthen enamel, and I'm going to talk about that a bit, alter the flora in the mouth, and control and alter the pH to really get this disease under control. And it's just food for thought. You know, most of us will jump into a case like this and start restoring immediately. But that's problematic. If you want to see your stuff just rot away, that's the path you take. Let's address the disease and go from there. Now, when you take a look at the radiographs for this poor patient and say, hey, how did they lose all those other teeth? Wasn't periodontal disease. In this case, it was caries. And that's very sad because we know unless we interrupt the disease, this patient's going to lose more teeth. It doesn't matter. Look at how they're rotting away under these restorations, under crowns. Teeth are decayed at the gum line, about to fall off. Look at the lower bicuspids on the right side. This is a terminal dentition left treated the way we have. Now, here's the one interesting thing. I use composites all the time. Composites are great for patients with low caries risks and low disease rates. They don't fare too well with patients with high caries risk or high disease rate. Here's a patient who was treated with initially some composites. And the composites were well placed. But the problem is, because of a lack of fluoride release, a lack of recharging, that patient kept succumbing to the disease because they didn't get it under control. Now, at least when we place a glass ionomer in an individual like this, where there's active disease, when we put that glass ionomer, we have a fighting chance. And what I mean by this is glass ionomers release fluoride in the presence of acids. And those acids come from caries or dietary acids. But here's the cool thing. You put in a GI in a high caries rate patient, the time you need fluoride is when the acid attack is occurring. That patient has caries, the acid will get under, fluoride will be released. So this ability to release things and fluoride ions when it's most needed is really one nice advantage to glass ionomers. Now, here's what happens in my practice. I practiced for 30 years. I've seen my patient population age. And as they age, they start to get geriatric caries. And I see all my beautiful work crumbling. Well, my first go-to material in geriatric patients with uncontrolled caries and really poor oral hygiene is a glass ionomer restorative. Look at Keytag. Have a box of that somewhere in your practice and make sure you're using that on those patients. Now, these use of GIs, you can do a lot of different things. Class 1s, Class 2s, as long as they're not a hugely stress-bearing. Class 5s is great. Class 3s, base liner, core material, and get that fluoride release. Why? That fluoride release in an acidic environment is essential to aid in remineralization of tooth structure. Okay, now, the other thing I want to mention on the restorative side of things is resin-modified glass ionomers. Now, 3M makes Reliax Luting Plus. It's a great resin-modified glass ionomer. If I'm rehabbing a patient and I'm concerned, I'm committed to do crowns, and they have a high caries rate, I'll actually look at a resin-modified glass ionomer as my luting cement of choice due to its ability to release fluoride ions, and it's rechargeable. It's got great bond strength to zirconia, good bond strength to composite. And in those patients where the disease really is questionable, high risk or moderate risk, I'm going to turn away from composite resin cement and try and utilize something that gives that restoration a fighting chance. Hope that makes sense for you. Now, let's talk the rest of this evening about the non-restorative management of caries and disease. And I want to really stress the need to focus on stabilizing the oral flora and controlling the pH. Now, how do we do this? First of all, great hygiene. But we're going to talk a bit about fluoride varnishes and some of the research there, sealants, the use of high concentration fluoride, and then xylitol products. And these are really 4 tiers of what I consider good post-restorative care. So what I mean by that is you do all those fancy restorations in a patient that had the disease, still has the disease possibly. What do you do to protect those things? To buy these restorations as much time as possible. And these are 4 of the strategies we look at. So we'll talk a little bit about this. Now, this was a very interesting meta-analysis that looked at 5% sodium fluoride varnishes as one strategy, resin infiltration and sodium fluoride varnishes as a second, and then high concentration fluoride, say 1.1% sodium fluoride, toothpaste or gel. And what they found was these 3 strategies, these 3 different strategies were the most effective at arresting or reverting non-cavitated lesions and cavitated root lesions, which is fascinating. And this is a really brilliant study in the Journal of Restorative Dentistry that looked at this. They did a meta-analysis. Now, meta-analysis is tough to do, but it's really one of the highest levels of assessment of the known literature. They looked at all these hundreds of articles and came up with a consensus. And I give them a lot of credit. Brian Novy was instrumental here, Wolf from NYU, and others worked very hard to come up with this meta-analysis. But it basically told us that if you're not going to do a restorative care, don't let the lesion grow, intervene. Intervene with sodium fluoride varnishes. You could use resin infiltration or high concentrations of sodium fluoride in a toothpaste or gel. And we're going to talk a little bit about this. This is an important study. Really looked at this. Now, look at this patient. They have disease. This is the disease of erosion. And remember I said earlier, we're going to talk a little bit about acids. This patient has no caries, but they have erosion. They're losing tooth structure another way through an acidic process. Now, it's more similar to caries than you'd think. First of all, acids break down the enamel, rob the tooth of fluoride, and as doing such, over time, we lose tooth structure. So when you take a look at this patient, I ask you, how old are they? Most of you would say, well, this looks like the mouth of a 70-year-old or a 60-year-old, but it's not. It's the mouth of a 32-year-old. This individual actually has extremely severe erosion. And this is chemical erosion. Now, keep in mind that caries is an erosive process through a little different mechanism, but it basically breaks down. When you look at the definition of erosion, caries kind of falls in there. But this patient had a habit. And if I asked you which of these drinks is the most erosive, I'm telling you, this patient drank the second most erosive drink on this list. Now, if I ask you which most erosive, a lot of you are going to say Coca-Cola. Well, hate to break the news to you, it's the least erosive on this list. And in fact, the most erosive is actually Red Bull. Now, we did a study, myself, Terry Donovan, and Ward Noble, on sports drinks, including Red Bull, and we looked at what's called the buffering time. How much time do you need to neutralize that drink every sip you take? Okay, and here's what we found. If you take a sip of Red Bull, you're acidic for 22 minutes. You're creating the perfect environment for the disease of caries and erosion. If you take a sip of Gatorade, it's 21 minutes. Powerade is 18 minutes, but oddly enough, Coca-Cola buffers or neutralizes very quickly in about 2.5 minutes. Now, this is interesting. Coca-Cola has the lowest pH. So if I'd asked you which one's the most acidic, Coca-Cola would be the correct answer. But I asked what's the most erosive. And it's actually Red Bull because of the time it takes to neutralize that. Now, these are all full of sugar. Take a look at that patient I just showed you who's 32. He's got a lot of erosion, but no caries. Why? He controls the bacteria. He still gets erosion because he drinks Gatorade through a Camelback during exercise for 3 to 4 hours a day. Hugely devastating. He's lost tooth structure to acid, but not in the way we lose tooth structure to acid of caries. A little different. There's non-bacterial loss of tooth structure. Now, this is a very interesting article that was in JADA that looked at this drinks in supermarkets. And what they found of the 379 drinks they looked at is 93% of them had a very low pH. Now, here's what's interesting. We say the caries rate's gone up in the United States. It hasn't decreased. We say the erosion rate's gone up. I see erosion all the time. And I would surmise that it's more about what we drink than what we eat, because these drinks are so acidic that they wear tooth structure very quickly. In the presence of bacteria, they'll cause decay very quickly. And in fact, I visited a few states lecturing where they talk about a process called mountain mouth. Not meth mouth, but mountain mouth. And mountain mouth is a disease process they determine is caused by Mountain Dew. So it's really important to recognize that these diseases of acid are prevalent. Now, let's talk a little about fluoride varnish. Nothing fancy here, but why is it in our practices, and I'm just saying the average practice, fluoride varnish is actually relegated to the hygiene department, and only the hygienist put on fluoride varnish. Now, if you're not one of those practices, if you've got a practice where the doctor applies a fluoride varnish or your dental assistant, kudos to you. When you look at the evidence of fluoride varnishes, it's there. It works. The reason it works is that there's a high uptake of the fluoride very quickly over the 6 hours to maybe 24 hours the varnish is present. You have a huge uptake in fluoride. And this is great when you've got glass ionomers on board because they'll uptake that fluoride. And then those fluoride ions are released slowly over time. But here's the deal. You need to reapply your fluoride varnishes every 3 to 4 months at a minimum when you're 18 years and older. So here's what I actually suggest you do. Think of fluoride varnishes differently. The patient comes in for hygiene and they have a treatment plan. You're going to deliver a treatment plan. And they've come back, say, a month later to do the treatment plan. And it's going to be a crown. And that crown's going to go out another 3 weeks. When that patient comes back, reiterate to them how important it is that you reapply the fluoride varnish. So what I like to do in my practice, and this increases our productivity, but not only that, it increases patients' ability to ward off the disease, is the doctor and dental assistant can apply fluoride varnish on a regular basis. Okay, because most of the time you see your patients every 6 months. That's not enough. The disease will get out of control again. So the evidence says every 3 to 4 months at a minimum. That's the ADA's recommendation. And in individuals with high caries rate, you'd want it even higher. So look at 3M's product. Vanish is a great product to use for the high caries risk patient. There are other really good varnishes on the market, but I want to focus a little bit on Vanish from 3M. Now, this is 5% sodium fluoride. It's important to recognize that the article that Novi did and others, the meta-analysis said that effective use of fluoride varnishes is essential. This is high parts per million of fluoride, okay? Now, not only that, and this is really important to recognize, that unlike other fluoride varnishes, this Vanish fluoride varnish contains tricalcium phosphate. Now, keep in mind, the disease of erosion and the disease of caries both have this in common. They leach fluoride ions out of the tooth, they break down hydroxyapatite, and take away calcium and phosphate. And to get really the trifecta, Vanish provides a source of fluoride for uptake, a source of tricalcium phosphate, which contains phosphate and calcium. So these products are now readily available for reuptake to help with remineralization. Comes in great fluoride, great flavors, and high fluoride concentration. So first and foremost, up your fluoride varnish game. You put in a crown, you cement that crown, tell the patient you'd like to protect it now by applying a fluoride varnish and allowing those ions to uptake over the next 6 to 24 hours and protect those teeth for the next several months. Once you get your patient on board with this, this is simple, really simple, and it can be a big game changer for your patients. So I really encourage you to do that. Now, number 2, sealants. Why sealants? Well, think about this. We now know that if you take an Explorer tip and go into one pit that's carious and lift that Explorer into another pit and poke at that pit, you can actually inoculate that site with caries. Well, that's frightening. So as dentists, we've been spreading the disease around slowly in the patient's mouth. Poking around with Explorers is really passe. We don't do that. But when we think about this, sealants decrease the areas that plaque and bacteria can accumulate on the occlusal surfaces of teeth. So I don't just think of sealants for little kids, but rather sealants are for anyone with active caries that you've placed in active caries or at the high to moderate risk for the disease. So rethink your sealant game. Seal adults if they've got high caries. Why not? Decrease the bacterial load by helping them out, especially if their hygiene's a challenge. Okay, so apply to those deep pit and fissures and lock those free of bacteria. You'll decrease the bacterial load. Lots of great sealants. I'm going to talk a little bit about why I like the ClinPro sealant from 3M. Now, a couple of things to recognize with this. First of all, it's got a great color change technology, which I really, really appreciate. When you put on the ClinPro sealant, it goes on pink. And as soon as you hit it with a light, it turns to this natural white color when light cured, which is really, really advantageous. It's very low viscosity. It's really one of the lowest viscosity sealants on the market. So it really runs into the pit and fissures beautifully. Not only that, it releases fluoride and it bonds to tooth structure. So up your sealant game is strategy number 2 to protect the restorations you want to save. And then finally, number 3rd strategy is prescribing high concentration fluoride. Now, 3M makes 2 really brilliant products, both with the ClinPro name. The first is ClinPro Tooth Cream, and the second is ClinPro 5000. We'll talk a little bit about those. Both of them are great for caries risk patients. With ClinPro Tooth Cream, I kind of reserve that for the moderate to low risk, not no risk, but low risk. You can use it for the high risk, but I'd recommend one other product, and I'll show you. But really, if you've got high risk patients and moderate risk patients, you need to decide to give them some form of fluoride, okay, in high concentration, and make sure to check compliance with those patients. Now, ClinPro Tooth Cream and ClinPro 5000 for 3M contain a number of ingredients that are essential for remineralization. First of all, of course, fluoride, and then secondly, are calcium and phosphate in that TCP formulation, which is essential for remineralization. We can't have it without a source of calcium and phosphate. So let's talk briefly about ClinPro Tooth Cream itself. It's formulated for low abrasion. It's got really good for moderate to high risk patients, and it contains 0.21% sodium fluoride, okay, 950 parts per million. This is not super high concentration, but this is good for those patients who've got their disease more or less managed. Okay, Now, if you've got the outer disease, where every time you see the patient, there is a new carious lesion attacking your restorations, you need to move to a prescription strength fluoride like ClinPro 5000. Now, keep in mind, this is a 1.1% or 5,000 parts per million fluoride concentration. It's going to be able to remineralize throughout the lesion, not just on the surface, that you generally see with a lower strength of fluoride. It's perfect for the high-risk patient and for those that we put at extreme high risk, meaning you know that as soon as you turn your head, they've got a new carious lesion. You're like, whoa, where did that come from? So keep this at the forefront of what you do. And then finally, the fourth protocol is xylitol. Now, xylitol is interesting. There's not a lot of evidence it does much good with children. That's probably because compliance is tough with xylitol. Why? Patients need to get to a therapeutic dose. But there is some good supporting evidence that xylitol in adults, at least, works well to curb the disease through interrupting the bacterial reproduction with our bacteria, Strep mutans and lactobacillus. So there's two protocols, gum chewing or mints. And you want to talk to these with patients. Some patients and my patients don't like gum chewing. So I'm going to go over two strategies. So here's the first strategy with xylitol. Keep in mind that xylitol has a therapeutic dose, and we're going to go over that. But overzealous patients may have a laxative effect with too much xylitol. So you have to warn them against that. A little too much can be a little too much. And keep in mind that it's harmful to dogs. You need to warn patients that they have dogs, keep their xylitol products safe distance from those dogs. Now, Theramints from 3M are mints that the patient can dissolve to get to a therapeutic dose. Xylitol found in Hershey's icebreakers for gum chewers is what I recommend. Now, when you look at concentrations of xylitol, it's important to recognize that some companies say, hey, we've got xylitol in our gum. Take, for instance, Trident. Well, that's a nice marketing thing, but the reality is you need what's called a therapeutic dose. What is a therapeutic dose? Your small patients need 6 grams per day. Medium-sized patients need 8 grams per day, and a large individual needs 10 grams per day. So kids are small patients, little old ladies, small patients. People of average build, medium build patients need 8 grams, and your larger patients need 10 grams. So take a look at Trident here on the right. It has 0.14 grams of xylitol. What that means, if you're a large individual, you need to chew 71 pieces of gum a day to get to a therapeutic dose. Now go to the other side. Hershey's icebreakers from Hershey's. Icebreakers contain 1.15 grams of xylitol per cube. What that means is if you take 2 cubes at a time, which is my strategy, you can get to a therapeutic dose with 3 gum chewing sessions for a small individual, 4 for a medium and larger individual. So you get to a therapeutic dose much quicker, and your pocketbook hasn't been hurt quite as much. Mentos says they've got xylitol. They put it right on there, and they do, but it's not a therapeutic level because you'd have to chew 30, 40, or 50 Mentos a day to get to a therapeutic dose. Now, Spry is another product. It's 0.72, and those are all gums. There's some other xylitol, xyla candies, but what I really like are the Theramints for patients who don't want to chew gum. Why? Because they've got 0.5 grams, and they're tiny little mints the size of, say, of a baby aspirin. And what that means is you can pop 3 or 4 in your mouth at once, dissolve them, and you'll get to a therapeutic dose very, very quickly. The neat thing that 3M's come up with through their Omni line is the packaging. When you get these, they've got a little container right on the top of the cap that allows you to put them in your pocket and reload it throughout the day. So it's really nice. This is a great thing to provide to patients and stress them the need to get through a therapeutic dose. Okay, that's really essential with xylitol. Now, I want to put it all together with a clinical case and give you some food for thought. And I think as dentists, part of the time we're detectives. I'm going to tell you the Starren story. This is a patient of mine who's become a great patient. At first, it was a little rocky. She was in a mindset where she blamed every dentist for every dental problem she ever had. Okay, so when things went wrong with her teeth, it was always the dentist's fault. All right, so Cecily comes in and she says she wants me to fix her implants and restore her broken teeth and fix the spaces between her front teeth. I said, okay, we got to take a step back. Cecily, tell me about your teeth. How did you lose your teeth? I always ask that patient, tell me about your teeth. And she goes, well, they broke. I said, okay, why did they break? Well, because the dentist didn't do very good restorations. Oh, okay. So you have implants because teeth broke. So let me get this straight. What led to the breaking? Were they root canal treated? Yes, they had root canals. Okay. So when you take a step back, how do they get root canals? Well, they got root canals from large restorations that got close to the pulp, then they died. So when you look at Cecily and you say, okay, how did this patient get this far down the restorative line? And the answer is simply caries. She lost her tooth or teeth due to caries. And that disease was really not well managed. Now, she has pretty good hygiene, and I've had tons of patients with great hygiene, but they still get caries. So what would happen? She'd get a large lesion. They'd do a large filling. That filling would inevitably cause the pulp to go south. She'd get a root canal, get a crown, because of her bruxism. And she was a bruxer. She'd fracture teeth. She began to lose these teeth one by one and get implants one by one, then a bridge on the lower right. And that was lost due to caries and fracturing. So ultimately, this patient had an out of control disease. And the first thing I need to do before I reconstruct is get these diseases under control. Occlusal disease under control. Periodontal disease, which she fortunately didn't really have, and caries. Using the prevention strategies we just talked about before I restore her, because she wants a full mouth reconstruction. I'm all in, but we need to do this logically, because who wants to see their beautiful case crumble literally before their eyes due to caries? None of us do. None of us wants to see all that hard work we do crumble before our eyes. So here she is. Well, she had let this disease go for so long, and her occlusion was so far off that I told her, hey, before I can reconstruct you, we need to get caries under control. You've got caries on certain teeth, under crowns. We need to get your occlusion under control. So you need a couple of years of orthodontics. It's like, oh my gosh, that's crazy. Of course, I know, but we need it because your teeth have super erupted. Then I'll reconstruct you. And then I'm going to give you some prevention strategies. And only then will these last. Now, when I look at the patient, I always make a list of observations. What I see in her mouth that's going against me, I like to write that, and going in my favor. And really, she had an asymmetrical smile, a gummy smile, altered curvus B, periodontal disease, thin gingival biotype. She was called a powerful other, many restorative materials, many root canals, high aesthetic demands, wants a perfect smile, parafunctional habits, and she's lost teeth due to caries, not perio. You know, she's got an underlying little periodontal disease. She hasn't lost teeth to perio. Okay, now that's all going against me. In my favor, she has most of her teeth. She is motivated and she can articulate what she wants, the perfect smile. On a scale of 1 to 10, she's a 10. Very challenging. Not only that, but she's challenging long-term. Will my restoration survive? So what do? We get her on those strategies. Fluoride varnishes, GIs where needed as a transition material, everything we've talked about tonight. We get her on ClinPro 5000. We get her chewing gum or dissolving mints, Theramints. She didn't like the gum because she already had TMJ, so we get her on Theramint. We tried the gum first because of higher concentration. That didn't work. Then we get her on Theramints. From there, we can redesign this case, design everything we want, and do the ortho, correct the curvus speed. Look at the time she's invested, the money she's invested in a full mouth reconstruction. Then we get this shade selection. This is hilarious. You know, I always show them the bleach shade guide. Sometimes, you know, I have to show them chiclets to ground them because she says she wants the whitest teeth. I show them corn nuts. We can use that as a custom shade. She wanted white teeth. I'm like, oh my gosh, we can give her white teeth. And we get all of that done. And we deliver the restorations in short order. We make her teeth and they're super white. But here's the neat thing. They're going to tone back. Why? Because these are translucent EMAX. So we get them bonded and they do in fact tone back. Then we did some veneers on her in the desired shade. And we bonded in these beautiful restorations. And in my opinion, we made her look 20 years younger or 10 years younger. She looks great. But here's the deal. I convinced her that the only way any of this survived was not because the dentist did bad work. It's because she failed her restoration. She didn't do what she needed to keep these. I said, so here's the deal. These restorations I'm going to do have no warranty. If one of them breaks from bruxism or rots away from your caries, you will pay for it again. And we'll keep losing teeth, and we'll need more than just the 3 implants you already have. And I was able to convince her that even though I was forced to do a full mouth reconstruction, that full mouth reconstruction can last indefinitely if she manages the disease through the use of fluoride, varnishes routinely, through the use of high concentration fluoride with TCP, ClinPro, tooth cream, with the use of these products, xylitol, and with the use of a night guard every night. Now, believe it or not, this case is out 9 years. A 9-year recall because she has been diligent about owning her 2 diseases, occlusal disease and caries. She has not chipped a restoration. She hasn't had one sign of caries. And that to me is hugely fulfilling. And it's cases like this where I spend a lot of time restoring them that I don't want to see my work crumble, because you know who's to blame? Oftentimes the patient's going to point their finger right at you. So keep that in mind when you do these restorative cases. What is your strategy for maintaining? And talk to the patient, have them own the disease, have them own their diseases, and have them manage those diseases. It's not about you. Think about this. We clean their teeth twice a year, maybe 3 times a year, some patients 4 times a year. If they clean them 3 times a day for a year, that's over 1,000 times. We get 2 cleanings, they get 1,000. I always tell patients, whether or not you keep your teeth, this has less to do with me than you. I'm going to give you the tools required. You're going to have to do it. And I said, listen, I do these same things. I chew xylitol gum. I use Theramins, both together. I have fluoride varnishes applied every other month. And guess what? I haven't had a cavity since I was a kid. I know what to do. Follow my instructions. Well, that's what we've got to do to patients. Yes, we get beautiful results, and this is a nice restoration. But will those restorations last? So with that said, I really want to thank you for tuning in tonight. I hope you follow me on Instagram at Marin Dentist, or on Facebook at Marc Geissberger DDS. And I encourage you to send me emails. Now, I'm going to go through the Q&A, and I saw a few pop up. I've got one question, so hopefully it's been pretty clear. This is great question from Greg. Greg, thank you for the question. Do you think sleep disordered breathing is something that needs to be addressed in these high caries risk patients? And absolutely. It's really interesting. I see a lot of patients with, sleep disorders with altered breathing habits. And keep in mind that sleep disorders often go hand in hand with GERD and grinding. You see that trifecta often. So I absolutely believe, Greg, that we need to address this in these high caries risk patients, because even if they're being treated for sleep disorders, say they're on a CPAP machine, that CPAP machine I've seen increases the caries rate. I've had a lot of patients who were caries free for many years, and they get on a CPAP, and although it's saving their life, they're more prone to caries, oddly enough. So sleep disorders is a huge thing. Increased caries rates are a huge thing with sleep disorders, whether they're being treated or not, because of this tie to GERD and other things that these patients often have as an underlying problem. So, Greg, I love the question. Thank you so much, and thanks for asking that question. So, let me just see under the chats. There's a few things. One question was, what's the role of xylitol? From Deepak. Deepak, that's a great question. Really, what happens with xylitol and bacteria is the bacteria that we have in our mouth attempt to absorb xylitol as a food source. they can't digest it. They actually break down. So that's really important. Now, Roya asked, hey, where can I get the caries risk assessment? 2 sources. You can go to the ADA website, or you can email me and I'll send you my personal one that I use in practice, and you can alter it with Word for your practice. So Roya, I'd be happy to do that for you. Just send me an email. And thanks for listening. Well, with that said, I'm going to turn it back over to our hostess and thank her for her work tonight. And I hope it was informative for you all. And thanks for joining.
Thank you so much, Dr. Geissberger, for the great presentation. And thank you again to 3M for sponsoring this webinar. If anyone has any outstanding questions, please email us at webinars@henryschein.com. And as a thank you for attending, everyone will receive the recording via email in next week. Thank you all for joining us, and we look forward to seeing you on future webinars.
Everybody, take care. Practice well.